once again for our favorite program, E-Gurukul Pathshala. I know we have not met since a long time, almost a 6 months, but the love for the E-Gurukul Pathshala is the same as I know. And I always have that love with all the students and all the teachers. They are always with me for the E-Gurukul Pathshala. We have changed something in the Gurukul Pathshala this time, for which more information our convener, Dr. Yogesh Parikh sir, will tell. So I'm not opening that Pandora box at present. We have the chief guest today, Dr. Neelam Mohan madam, but she will be joining us shortly. Till that, I'm giving this platform to a new coordinator who will be coordinating for the e-Gurukul program now onwards. So I welcome Dr. Lata. She is Associate Professor at the MK Shah Medical College and SMS Hospital, Ahmedabad, and a very enthusiastic person. She is always there when I need some help regarding the PG teaching and the programs. So that's why sharing my responsibility to her. Welcome, Lata, and please go ahead with the program.
Thank you, ma'am, for your kind words. Good evening, everyone. I welcome you all for this new platform. I'll say new because this is New Year, and so we're starting fresh. So, without wasting time much, we'll straight away start the program by welcoming our convener first. I welcome the convener of this program, the Commission Beyond Introduction, Dr. Baldev Prajapati, sir. He is Professor Emeritus and Director, Medical Education and Research, Bhagyoday Medical College, Kadi. His expertise and contribution to PG teaching program has crossed decades. Welcome, sir. Nehal ma'am, you want Yogesh sir to brief regarding program first?
So, thank you, Lata, for introducing, sir. Before we handle this entire platform to Baldev Prajapati, sir, we have Dr. Jhankhana madam here as our AOPG president, and I request her to give her message for the presidential address, as this is one of the AOPG's presidential action plan, and we know that she is so much enthusiastic plus passionate about all her presidential action plan. So, madam, please, your blessings.
Thank you, Nehal, Dr. Nehal. Good evening, friends. I am very happy to welcome you all on the occasion of the E-Gurukul Pathshala relaunching program. I welcome Digan Sastri sir. I welcome Dr. Baldev Prajapati sir. I welcome Dr. Yogesh Parikh sir. I welcome Dr. Lata as a coordinator. I welcome my own OB office bearers, Dr. Nehal, and I welcome all delegates for this program. See, the Gurukul education is an ancient Indian wonder. Look at the students of the Gurukul. See, Arjuna, Dr. Sri Krishna, Bhim, and even Duryodhan also. Duryodhan is with Adharma, we all know, but is an excellent, knowledgeable person. I think he is a better in a Gadayud with a Bhim also. So Gurukul has given us a lot of excellent, great teachers. Gurukul is always with a great gurus. And with this program has brought the best guru for the PG students to help them to cross the Sat Kotha of this PG exams. So all the best for this program and best wishes for the success of this program. Thank you.
Thank you. Thank you so much, Jhankhana madam. So, for the introduction of the program structure and the change in the program structure, I invite Dr. Yogesh Parikh sir, who started this vision of e-Gurukul Pathshala in his tenure. And now it is the baby which was born at that time is now a toddler at present. So, sir, please, your vision about this and the program.
Thank you, Dr. Nehal madam. So, respected our President, Dr. Jhankhana madam, President AOP Gujarat, my dear friend and mentor, Dr. Digan Sastri sir, our academic guru, Dr. Baldev Prajapati sir, Dr. Lata Jha, Dr. Mehul Gosai, and our all the participants who have joined on the digital platform. We are waiting for our today's chief guest, respected Dr. Neelam Mohan madam. it is a very immense joy and the privilege to welcome all for the relaunching of the e-Gurukul Pathshala, very initiative during the tenure of the my presidency in the year 2021 as a action plan of the Academy of Pediatrics Gujarat. So this platform is not just a digital classroom. As Dr. Nehal Madam mentioned, the seeds and newborn period started during the 2020 with our past president and the guru, Dr. Digas Sastry, sir. We were planning the AOPG action plan program of the 2021 uh, while the COVID was there. And we are thinking about the something for the PG students as a medical teacher and the pediatrician for the academics. So we are thinking the name and this e-Gurukul Pathshala we have started at that time as a action plan program of the 2021, and it was continued in the 22 also, and thereafter while I was the vice president of the West Zone, Dr. Nehal Patel Madam managed the whole program with the West Zone. Again, I thanks Dr. Jhankhana Madam for the taking this initiative to roll launch on this digital platform to nurture the excellence and the foster collaboration and empower the next generation of the pediatrician with the knowledge, skill, and the confidence. So, as we have a something change in this program in the 2021, it is as a PG clinic program in the Saturday evening 6 to 8 and Sunday morning from 9 to it is 12 or 1 o'clock. The expert panel discussion with the various subspecialties and this academic program. And we know that during the COVID, more than 2,000, 3,000 pediatricians and the students were joining the program. And AOP Gujarat is well known for this initiative because this is the first kind of the program in the whole country for the PG and the PG teaching. So this year we have starting this with the four other things. Today we are launching the OSCE session by the experts. Our own mentor and the academic guru, Dr. Baldev Prajapati sir, is agreed to conduct this every first of this month for the OSCE session. And the second is the PG clinic for the case presentation. Again, we have a subspecialty with the other systems. We are analyzing them critically for the students to prepare for them for the PG exam because we know the after the COVIDs the PG teaching very much affected and that time also and now PG teaching is very important and very necessary to practice and build confidence in the clinical decision making. So again the Baldev Prajapati sir will mentor here and we are inviting the medical colleges to present the case wherever the from the our uh, other departments. Third will be the faculty, this expert faculty and the panel discussion. So one moderator will be there, four panelists will be from the other system will be there, and then the next session will be the quiz, interactive quiz session. Our Dr. Prashant Karya will manage this, and learning is most effective when we engage everyone. So quiz session will combine with fun and some encouraging active participation and quick thinking and he will manage this concept and in between we have also journal club also for the advanced research. So this 4-5 format will be some change because previously we are having only PG clinic Saturday and Sunday the for the pediatrician. Now PG students and all the pediatrician who wants to learn from the e-Gurukul, they can join the program and they can have share their knowledge, expertise, and have these sessions. So I think it is enough for today. So I think I welcome Dr. Digan Sastry sir to give some input regarding the e-Gurukul. Digan bhai.
Yeah, thank you, Yogesh bhai. Respected President AOPG, Dr. Jhankhana Ben, Secretary Dr. Nehal, Dr. Yogesh Bhai, the brain behind this program, and of course, the soul of this program, Atma of this program, Dr. Baldev Bhai Prajapati, without whom we cannot run this program. And I'm happy to see Dr. Lata taking over the new responsibility. It's a good sign. See, the leader is one who creates leader. So, Nehal, it's good that you and Jhankhana has found out a person who is taking up the responsibility. All the best, Dr. Lata.
Thank
I
you, sir.
welcome Dr. Kalpana Dattaji, Dr. Ashwini Agarwal, Dr. Mehul, my dear friend, and many other friends. It's a pleasure to be in the reincarnation of the E-Gurukul. Earlier it was E-Gurukul. And I remember the name I had suggested Gurukul and E because it was a e-learning and Gurukul is a learning platform. So in those days, as Yogesh Bhai very rightly said, in 2020 we were discussing and we thought that it is a very good platform we can use. And we had a section for the practitioners also, where on every Sunday morning there were subspecialty discussions. And Dr. Abhay Shah sir was coordinating this, and along with
Chetan Bhai
Dr.
also.
Chetan Shah.
Yeah.
So it's a congratulations to Dr. Jhankhana and team for again restarting this. And in the current time, again the assessment methods have changed compared to the previous years. Previous years there was only theory paper and then there were long case, short case, stable vivas. But now we have the OSCE and other things. So it's good that we have incorporated this in the second edition of E-Gurukul. And when Baldev Bhai is there, he was my teacher during my PG days, and he is my teacher today also. I'm learning from him, and it is always a pleasure to listen and learn from him. A person with a very clear fundas and person with a very sharp memory. I remember many times he used to quote the page numbers also of the Nelson. So when you have such a person as a teacher, as a mentor, I am sure the not only the students, the PG students, but all the delegates, all the listeners, even the faculty members also will be benefited by his academic knowledge. I wish this program all the best and look forward that there will be large number of PGs all across the country. They will take the advantage of this initiative. Once again, congratulations to the AOPG team and thank you for giving me this opportunity.
Thank you, sir.
Thank you, sir. So with this, uh, we are starting our program, and with the blessings of Almighty God and all our seniors and mentors, the I also wish this program a great success and all of you, all of the learners who has joined, a great learning also. Because, and I can assure that because we have Baldev Prajapati sir with us. And since 3 years, as I'm seeing, heads off to him. Such a dedicated person for a teaching. So, sir, the platform is all yours.
Dr. Nehal, there is one name, Araklas S25. Is it Dr. Arkala Bhaskar or
I don't
somebody
know, sir.
else?
Ashwini Agrawal sir is there.
Yeah. Ashwini Agarwal, I took his name, but
Good evening, sir. Good evening, sir. Digant sir.
Yeah.
so we have the vice
Yogesh, sir.
president,
Vice
and I
President,
think
yeah.
we can have blessings from
Yes,
him.
yes. Yes.
No, sir. I am participating as a student.
No, but
Oh,
still,
please.
just
Thank
to
you so much
two,
for
two
joining,
lines.
sir. And please give a blessing to our program.
Definitely, madam. I wish all the participants to have a very good, great learning experience. Thank you. Thank you, Yogesh ji.
Thank you, Arakla Bhaskar, sir. Thank you for joining and blessing the AOP Gujarat program.
Thank you, sir. Thank you.
Now the platform is all yours, sir.
Good evening, friends. Am I audible?
Yes, sir.
Yes, sir.
So now I am muting everyone except the Baldev Prajapati, sir.
President of AOP Gujarat, Dr. Jhankhana Ben, Secretary, Dr. Nehal Ben, Coordinator, Dr. Lata, our Yogesh Ben, who is, I will say, brain behind this program, Dr. Digant Ben, past President of Indian Academy of Pediatrics, all other friends on the screen, anyone off the screen, those who are on the attendees link. Thank you very much, Dr. Digant, for your kind words. I understand my responsibility once I accept it, and I'm sure that we'll be able to fulfill the expectations of the students. All of us know that learning is never ending. And if we continue,
Sir, you have muted yourself.
Not muted, but some audio problem.
Yeah.
am I audible?
Yes, sir.
Yes,
Yes.
now you're audible.
Okay. Whatever at least we are, I will say, discussing with the students, but while interacting with them, we are also learning a lot. And this is certainly the good platform, very appropriate platform for learning, even for all of us. Of course, more so for the students. And as already program is modified, I'm sure that it will be interesting. And even it will give these, I will say, expectations for not only the PG students, but even the practitioners and even those who are interested, even as the faculties. I understand that this program is going to be the good one, and congratulations to all the, I will say, people, those who have taken the lots of the pain for organizing and to at least or making this good platform for the interactions. I think the first beginning or initiation is the OSCE. All of us probably must be, faculty at least must be knowing that now OSCE I think there is some in between net issues on my part or at some other, because I thought that it was not working for a few seconds. Anyway, it happens. So then please let me know.
Yeah, definitely, sir. We are able to hear you.
Yeah. You know that the OSCE is now gradually, not only for the DNB exam, even for the MD exam also, it has been, even the NMC has conveyed to most of the universities. Some universities still not able to manage due to the logistic reasons, but in the very short time, it is going to be the part of you in the MD examination also. And all of us know that OSCE is such a pattern of the assessing that unless the candidate knows the details, very difficult to attempt and to get through this pattern of the OSCE. And therefore, I'm sure that all the students will be interested. Second, let me mention that recently one of the books I have published, and that is for the postgraduate exams. More than 600 OSCEs are included in that. Many of still I'm going to include it, and I'm sure that while discussing, we'll take the help of most of the topics to be covered. With that, should I now start sharing?
Sir. Yes, sir.
Okay, so I do it.
And my request to all the PGs who have joined, please make a successful program by interacting with the questions. Sir likes maximum interaction, and that's the beauty of this program. So please
I
interact.
think absolutely. And I think I'm sure that with the interactions, all of us can learn a lot. Whether my slide is visible?
Yes, sir.
Yes, sir. Yes, sir.
Is it full screen?
Yes, sir.
Perfect.
Okay, so fine. Now the first, I will say, the chapter which we have selected is the gastroenterology. And therefore, OSCE should be restricted to only this chapter. Let me start with the first one. Please, all the students should be active and put even your, I will say, comments on the chat box. I will check it. Here it was an 11 years old male child was admitted for jaundice and high colored urine for 3 months duration. Clinically, vitals were stable. Child was afebrile. Jaundice was there. No pallor, no lymphadenopathy. Liver and spleen both were enlarged and firm in consistency. Eye examination was contributory. Bilirubin was 4.5. Direct eye. SGPT was raised. CBC coagulation profile was normal. Seromarkers for viral hepatitis were negative. And child was born of a consanguineous parents. His elder sister died at the age of 7 years due to the similar illness. This is the case scenario. And I wish that if somebody is, I will say, interacting on the screen, that's good. That what is my first question, what is your most probable diagnosis in the given scenario? I hope that you know this case, which already I described.
You can even unmute and answer. So it's not, yes, it's not compulsory to write in the chat box. You can unmute and answer.
Yes, you can. This was the question. Just to remind you, this was the scenario. Anybody? What is your probable diagnosis?
So the answer from in the chat box is Wilson's disease.
Yeah, I think Lata, I will have to check. Somehow I'm not able to check.
Okay, sir. Okay,
so
sir.
You can
Sir,
check.
Wilson's, I am galactosemia. Two persons have answered Wilson.
I think whatever the responses are, I think you can give me. If one is the Wilson disease, another is the galactosemia. Okay, very good. Anybody can give the explanation that why you are thinking for the Wilson disease? Please come on the screen, then it becomes a good discussion. Any student?
Yeah, you open your video.
You keep your, I will say, video sharing on the screen and respond even, I will say, with the interactive session rather than putting on the chat box so that it becomes more interesting. I will say answer is Wilson disease, yes, right. If you go back, here the child is 11 years old. Problem is since 3 months. Galactosemia will start early because as soon as the mother starts the breastfeeding or any feeding where the galactose is there, that galactitol substance will deposited and problem will start. Therefore, in the early infancy, hypoglycemia is common. Yes, jaundice can be there. Splenomegaly can be there. But with the same time, the age will be different. Yes, eye examination even, you may get the cataract. In that situation also, it will be contributory. But looking at the age of the patient, looking at the onset of the disease at the age of 11 years, and even the other features, it does not favor the galactosemia, but yes, Wilson disease. That's the right answer. Now the next question. What would be the finding on eye examination? Suppose if you are thinking for the Wilson disease, what finding you will get on eye examination? Already I said, suppose galactosemia, you will get the cataract. But suppose Wilson, then what you are expecting that you may get it?
Sir, answers have come, KF rings.
Okay. How many, I will say, responses are there?
Sir, one PI has responded, 1, 2, 3, 4, 5, 6 responses.
Okay, fine. I think at least gradually I wish that the participation should increase. Yes, very certain that KF ring. KF ring should be seen. Then there's some questions, suppose why is there? Examiners may ask that KF ring can be seen whether this naked eye may not be in all patients. But some of the patients, even KF ring can be seen by naked eye. But if it is not seen, please always go for the slit lamp examination. In slit lamp examination, more chances of getting the KF ring. and that KF ring is the deposition of the copper in the Discman's membrane of the cornea. That's, I will say, details of this ring. And all of us know that KF ring will be more common, particularly in the older children. Particularly, there are two types of presentation of Wilson. One is the hepatic involvement, second is neurological. Somehow, neurological manifestation may have the more chances of KF ring. KF ring is present, it will help you for diagnosis, but absent does not exclude the diagnosis. So that we should know. Anyway, the further question, name the other confirmatory laboratory investigations for this disease. What other test you will do? Clinically, you have suspected, it is supporting, KF ring presence, yes, highly suggesting, but then what laboratory investigations you will do? Yes, come on. What are the responses?
Copper level, 24-hour urinary copper, 2%, copper level 1, serum ceruloplasmin. I think he's trying to write ceruloplasmin.
Right.
Liver biopsy, ceruloplasmin. 4
Right.
have written ceruloplasmin, 1 copper, 2, 3 liver biopsy, and that's it, sir.
Very good. I will at least convey to the students, these answers are right, but for the undergraduate student. For the postgraduate, your responses should be very precise. And even for more scoring, always go for the, I will say, precise answer. Answers are right. Let me put your exact precision. Serum ceruloplasmin usually less than 20 milligram per deciliter. How much low? Low, yes, but less than usually 20. Urinary copper excretion is more than 100 microgram per day. But most of the patients, commonly we get more than even 1000 microgram. And hepatic copper content, please remember the very precise answer, more than 250 microgram per gram of dry weight of the liver tissues after the biopsy. Not just liver tissues. The hepatic copper should be more than 250 microgram per gram of dry weight. So that I will say examiner will not dare to cut off any mark. He has to put the 100% mark. So again, I want the attention of the students that not just answer, your answer should be very precise. Anyway, further question. What is the specific treatment of the condition? Yes, now Wilson is confirmed. And even if I provide more information, consanguineous marriage, that points also supports because it is an autosomal recessive. Already death of one sibling due to the similar illness, that means it was not diagnosed or diagnosed but not managed properly. So now, what is the specific treatment? Yes,
Sir,
Dr. Lata?
4 persons have written penicillamine, 2 have written zinc, and 2 have written both penicillamine and zinc. More of penicillamine they're coming up.
Fine. That's a good responses. Let me go for the very precise answer. Yes, it is a D-penicillamine, and D-penicillamine is 20 milligram per kg per day. And zinc is 25 milligram, even 2 times, 3 times per day. Yes, management, please remember that the restriction of copper is very important beside this medicine. Somebody will ask here some question. Let me even put this other questions also simultaneously with this. Why zinc we are giving? What is the role of zinc in this management of these patients? D-penicillamine, yes, that will remove the copper. But then how the zinc is required? What is the role? And some even the gastroenterologist will say, in some patients, that I will not give the zinc. So what is how the zinc is useful, or what is the role, or why we are offering the part of treatment? Yes, anybody?
So students, please answer by unmuting yourself, please.
Yes, please. I will say without any hesitation, please don't hesitate. It may be wrong answer. No problem. Every person does not know. Even suppose if you ask me spontaneously, even I may not be able to answer so precisely. I have come with the preparation. That's why.
So somebody has written competes with copper. Another one has written copper transport. Then impairs GI absorption of copper. Dislodges copper as both are bivalent. 4 answers we have got.
Anyway, So I will understand in the exam, suppose student is responding that having some idea, some concept is that, but clarity is not there. And the clarity is that once you are starting the deep penicillamine, it does not chelate only copper. It chelates even the zinc also. And if you don't supplement, some children will develop zinc deficiency. Therefore, considering that deep penicillamine chelates the zinc also, and therefore go for the supplementation to prevent the zinc deficiency manifestation. That's the answer. And restriction of copper, yes, and how much, even the restriction, less than 1 milligram per day. That will be the answer. Anyway, further, here somebody will ask that what is the toxicity of the deep penicillamine? Suppose already you have started the deep penicillamine, or even somebody will ask that how will you monitor and follow up for the deep penicillamine toxicity? You know, all the questions I may not be put in the OSCE, but here some other examiner may put some other question. So suppose deep penicillamine is already going on the follow-up monitoring, what test or what things you will monitor for the deep penicillamine toxicity?
So someone has written CBC with pancytopenia.
Okay, anything else?
Cell counts. Another one has answered cell counts.
Okay, suppose if I give the hint, it creates some renal problem, and therefore urine routine is very essential on follow-up of every patient on the deep penicillamine. So what problem is likely?
SLE good pasture syndrome.
Okay, I think I will have to read again if answers are in this way. At least if I can say no good pasture, no SLE. SL is due to some other drug. Later on I will come for that question. But deep penicillamine, and you know that toxicity of the problems is a very common renal condition in our pediatric practice. That what
nephrotic syndrome.
Yeah.
Nephrotic syndrome.
Therefore, nephrotic syndrome is known with the deep penicillamine. And therefore, yes, it can cause even the leukopenia, thrombocytopenia. So CBC is correct answer. Go for the urine examination, particularly albumin. And if the patient complains of suppose edema or something, keep in mind that nephrotic syndrome can develop. What dietary advice you will give? Please, nowadays, this is very important. Counseling, dietary advice, even the genetic counseling, these questions are going to be there related to problem of the patient. So here, dietary advice. What dietary advice? That means which diet they should not take, which is likely having the significant copper.
So they have written avoid nuts and chocolate.
Very good.
Chocolates, nuts and chocolates. These are the answers coming.
Very good. Yes. Good answer. I will consider. Avoid copper containing food like liver, shellfish, those who are on the diet. Nuts and chocolates, very common. Perfect answer. And very important, even avoid storing or cooking in copper and brass vessels. Fortunately now, it is not the tradition, but it was there. And suppose still some families are following, we can explain them that better to avoid this one. You know, so what is the idea of the OSCE? That it will cover the whole topic. And if you are knowing very precise answer, then you can respond on the Wilson disease. Not just you can write down some few lines that Wilson is the disease with the liver involvement, it can cause jaundice, it can cause these things. Not like that. Therefore, the questions are going to be in this manner. This is just illustration. This type of any question can come. And I'm sure that in the OSCE, even I can, on the first OSCE, let me make the point clarify that exam going students, if they attend all the OSCE, I'm sure that their performance is going to be better than their friends, those who are not attending. Certainly because we are going to cover in this fashion. Let me go to the second question. A 3-month-old male child was referred for with the frequency of stool 15 to 20 times per day and watery. And this is since birth. He was full-term baby with birth weight was 2.9. That means good weight. He was found with severe dehydration, hypokalemia, hypochloremia, and metabolic acid alkalosis. Please listen to each word. I am giving the hints. It's a 3-month-old child. Problem of stool, water stool, and almost since birth. Baby was otherwise at the time of birth good, full term and weight 2.9. But on presentation, severe dehydration, electrolyte disturbances with your metabolic alkalosis. My question is, what is your diagnosis?
The 3 answers have come. 2 have answered cystic fibrosis. One has answered Hirschsprung. One more, Barter's. And another one has a CT. I think he is also trying to write cystic fibrosis.
Okay,
So
I will
core
appreciate.
cystic fibrosis. Huh?
I will appreciate the responses. But examiners are also putting the puzzles. Looking like, I will say elephant, but really it may not be the elephant. So I appreciate that cystic fibrosis. Yes, let me go back to the slide. Is a 3-month-old child referred for frequency of stool. Watery stool is not the characteristic of cystic fibrosis. The stool is going to be maybe numbers, but usually sticky, oily. Here it is watery, which is not characteristic. Okay. Cystic fibrosis maybe is going to be good at the time of birth. Yes, so it is right. Dehydration, severe dehydration is not the characteristic of cystic fibrosis. On the contrary, failure to thrive is a characteristic of this. Hypokalemia, yes. Hypochloremia, yes. Metabolic alkalosis, yes. And I think that's confusing to the candidate. Therefore, most of the answers are going to be cystic fibrosis. Even on the contrary, I have not put the question, but after preparing this OSCE, I thought that I may put the next question. What are the differential diagnoses? And differential diagnosis, yes, you can put the Bartter syndrome. You can put even this cystic fibrosis, and you can put the real answer, which I am going to reveal later on for this condition. Please remember another thing, that the Bartter again will present with a failure to thrive. And in spite of, I will say, there is no obvious loss. There is no frequency of stool. But still, these are the some points how you can. This is rare condition, but in the OSCE sometimes rare condition also they will ask us to confuse. Answer is, in the Nelson only one small paragraph is there. As already Dr. Digant was telling, sometimes it was my habit of conveying to the residents in the round that open the Nelson, this page number, and you will get the answer. And that very small paragraph is there. That is a chloride losing diarrhea. It's a chloride losing. I have seen probably 3 or 4 patients only, but you can diagnose if you are aware of it. And please check your Nelson. You will get this condition. Next question, but very important. What is the basic defect in this condition? If anybody is able to recollect, what is the basic problem in this condition? Chloride losing diarrhea, where the chloride is lost?
No answer still now, sir.
Anybody?
No, sir.
Yeah, I understand. Difficult to answer. Basic defect is the transport mechanism of chloride at the distal ileum. And this is really very serious condition. Most of the patients don't survive. I have seen most of them after 6 months, 8 months, beyond, I would say, even before infancy, we lose them. What finding is common in antenatal USG study in this disorder? Antenatally, if you go in the details, I will say again, then you may get the history. What is the history? Anybody? Anybody?
No, sir.
I may put the question, suppose in the Viva in this way, that what is the important point in the antenatal, may not be USG, but USG or otherwise, antenatal point in this chloride losing diarrhea, in Bartter syndrome, and in cystic fibrosis. What will be the important point? So please remember here, you will get the polyhydramnios. Maternal polyhydramnios. Please remember, maternal polyhydramnios is also common with Bartter syndrome. And please remember, antenatally or even at the after the time of birth, you may get the meconium ileus or even sometimes meconium colitis. So that favors the cystic fibrosis, but good responses. Let's go to the further question. This is one investigation which were performed in an infant who presented with vomiting, irritability, and failure to thrive. The investigation was favoring the my diagnosis. You can check the investigation that what does it show. And the
Answer has come.
question is name the investigation and condition. What is this investigation and for what condition it favors?
So Manish sir has answered. TC scan for milk aspiration. Technetium 99 scan.
Yes. Who has answered?
Manish sir.
Dr. Manish Mehta.
Ji sir.
Yeah, that's good that at least he is there. Manish, naturally, he will be able to answer.
Yeah. One more person has answered, sir. Technetium 99. Oppo CPH 2223. I don't know. He has not name. Please name yourself. Residents, please name yourself. It will be easy for us to communicate.
Anyway, this is the milk scan. And of course, as Manish said, it is GRD. But the next question, why the child is irritable and having the arching in this condition? Many a time there is the arching, so much irritable child. Yes, it is the GRD, but why then this so much irritation? And why the child is even in the arching condition?
Reflux esophagitis.
I think Manish must be answering.
One more person, reflux. Two persons answered. Sandifer syndrome, somebody has answered.
Very good. Yes, this is a reflux esophagitis. Child is quite irritable. And even Sandifer syndrome also will be also one of this type of presentation, even arching. And some people will even interpret as the seizures also. So that difference is, if you are knowing, you will not do the mistakes. What are the other investigations for diagnosis of this condition? Are there any other conditions? Investigations?
pH. Somebody has answered. Omkanath Swain. pH.
pH where?
24 hours pH monitoring.
Very good. That's right.
Now he has written correctly.
Yes. Anything else?
Esophagus pH and manometry. 24-hour pH monitoring. Manometer 24 hours.
Very good. Anyway, as already we can go for the contrast barium study. Esophageal pH monitoring, absolutely right. Even endoscopy, you will get the changes of gastritis and esophagitis and other indirect evidences. And then what pharmacotherapy is considered as the most potent? Many things already we are prescribing, but which one scientifically consider that it is the most effective?
PPI. Everybody is answering PPI.
Very good. Very good. Very good. This is a proton pump inhibitors. I think more details is there in some other case, so I will wait for that. Right? Let us go further. All these cases, let me tell to the student that these are my own, I will say, collection, even the photographs and everything from this collection only. This was a 2 months male infant, presented with complaints of non-bilious projectile vomiting for 1 month. He required the hospitalization for neonatal hyperbilirubinemia in neonatal period. Baby was not gaining the weight, and on examination, moderate dehydration was noted, and ABG was performed, which showed the pH, bicarbonate, SpO2, these figures, and even below is the picture of upper GI contrast study. I think full-fledged picture is given. And my question is, what is your interpretation of ABG first? If I go the back, what will be the interpretation of ABG? You know, here examiner wants interpretation of the ABG, that how much you are competent to interpret the ABG. That's the thing. Yes, anybody?
Yes, sir. Metabolic alkalosis.
Of course,
Three
very good.
persons have answered. One has written metabolic acidosis. Another have written, sir has written, Manish sir, hypochloremic metabolic alkalosis. And one more has responded with metabolic alkalosis.
Yeah, I think you know that the pH 7.55, 7.35 to 7.45 is a normal range. So 5 is quite obvious alkalosis, not acidosis. So from the pH, one thing is very certain. Look at the bicarbonate, it is quite significantly raised. Normal, I think 20, 24 or so, maximum. So 44 is significantly raised. And if you put as a whole, it is a metabolic alkalosis. Now the next question, what are the radiological findings? What are the radiological findings? It is upper GI contrast study, already I have mentioned. What does it indicate? What are the findings? You know, that is the beauty of the OSCE. You are knowing the condition is not important. You should know the each aspect. So here the interpretation of
pyloric stenosis also radiological findings, sir.
Radiological interpretation.
Pyloric stenosis ma radiological findings, sir. Variable.
Yes, anybody?
So yeah.
Lata?
Yes, sir, Manish sir has answered gastric outflow obstruction, Charita's iPhone as pyloric stenosis.
Yes. You know, here, interpretation point of view, if I try to show with the cursor, I hope I will be able to do. One thing is, this is the stomach and this is the pylorus. So it is a very strong, I will say, long line. Then this is the, I will say, pouch. What many people say, I will say, pouch, the duodenal pouching. And this is the, I will say, elongation of the pyloric canal. And the radiological names are given. Let me show that elongated pyloric canal is called as the string sign.
Make it a string sign.
Bulge of the pyloric muscle into the antrum is called as the shoulder sign. And parallel streak of barium in the narrowed channel is called as the double track sign. If I go back, let me show again that this is the string sign. This is the, I will say, shoulder sign. And this is the double track sign. So even, you know, sometime in OSCE here, the point is, where is the beauty of the OSCE? Unless you are knowing this interpretation appropriately, you will not get the mark. Next question, I think now diagnosis is obvious.
Strings.
Congenital hypertrophic pyloric stenosis, which was mentioned by some of the friends. And it was
right. Shoulder sign.
Excuse me, sir. Dr. Anisha, please mute yourself. Dr. Anisha, please mute yourself if you are not answering.
Hello.
Sorry, sir, for interrupting.
Lata, you can also, I have made you the co-host, so you can make everyone mute. Huh?
Okay, sir.
Yeah.
Okay, sir, I will do it.
You know, what are the other diagnostic modality is sensitive for the diagnosis? What else you can do? Anybody?
USG, sir. Ultrasonography.
Very good.
USG abdomen, 2 persons have answered.
Ultrasonography, and nowadays, you know, probably we don't go much for the contrast study because it is a 90% sensitive and very good, even with a good sonologist. We may not go for this contrast study because it is also having some of the problems. And then what is the surgical treatment? What is the surgical treatment?
No answers till now. Ramstead pyeloplasty.
Very good.
Ramstead pyloromyotomy.
Yes, very good. So the answer is absolutely, you know, here from the serosa, just you put the cut, reach to the muscles, opening. What is called as a pyloromyotomy. And that person who devised this operation is Ramstead. So Ramstead's pyloromyotomy. This is a very simple surgery, surgeon point of view, and very good results. And if you have not diagnosed many a times, due to the complications of metabolic alkalosis and electrolyte derangement, patient may die. So I think that's very important for the clinician and not so uncommon. Yes, we do get such patients. I have decided in the OSCE, I will not be in hurry to complete. We can take even, I will say, longer time every time, but whatever we will do with proper understanding so that it will be useful, not only, I will say, the exam, but in the practice also. I think Manish must be knowing many things, but it will be the good revision to the practitioners also. Let us go further. This is some chart I have taken. Just look at the chart. Then I will put the questions. And I hope that we should be familiar with the chart. What is the name of this chart?
So they have started answering. Bristol stool chart, 4 persons have answered.
What mentions? What
Bristol chart, stool
very
chart.
Good, very good.
7 persons have answered till now.
Very good. It's a Bristol stool chart. Next question, but what is clinical application? Why we use this type of the chart? I think practically probably people don't use. My main purpose of this question is to sensitize you and the practitioner. And nowadays, even your mobile, in your laptop, in your computer, you can keep it, show to the parents, explain them. It will help us a lot rather than any investigation.
Yes,
so
sir.
what is clinical application?
So 6 persons have answered constipation. One has answered grades of constipation. One has answered for patient education for constipation. So we have got 8 or 9 responses.
Right. Yes, it is in constipation, but in constipation, how we use it? Our use is, patient with constipation can identify the stool pattern. Mother can define that what type of stool of that particular child with the constipation is there. And that will inform the clinician that what is the likely problem. If I tell that how various conditions can be diagnosed, directly if I go for the answer, if it is a normal consistency or constipation, that you can decide from the chart which already have been shown. Suppose the constipation, but pasty stool, long paste-like stool is more common with the Hirschsprung, while large and hard stool in functional constipation. Very simple point, just if you ask the mother, or even the mother brings the photograph of that fecal matter, or if you show this chart and ask the mother that can you decide that what type of this stool is seen in your child, that will give the idea. Very simple, I will say point, but give the lots of idea for further evaluation for the constipation. And that's why that this chart should be, I will say, popular among the practicing pediatricians. And that's why, Lata, job of the faculty is to ask in the exam. If you ask in the exam, they will prepare.
Yes, sir.
If they prepare, they are familiar. If they are familiar, they will use in the practice. So, this is the thing that how you can make the people to think and to translate it in the practice. So that's why I will say this is even how the faculty can make, I will say, once it made the wide in the use, suppose my book is there, those who are reading, many students will remember it and they will say, oh, I have seen, it's not new. And once he starts to use in the practice, he will understand, realize that yes, it is important. Anyway, let us go to this similar chart. Again, it is some abnormal stool colors and normal stool colors. This is the chart. I am sure that many friends must be familiar. Let me put the question. This card is prepared for identification of changing color of the stool of infants. Then what is the name of this card? What is the name of this card? Very simple name. It's not complicated. Please, please don't think complicated things.
No answer till now, sir.
Okay.
Stool color card.
That's why I said very simple. It's a
stool color card.
Yeah,
someone has answered.
Stool color card, yes. My main concern or the question is, what is the interpretation of this card? Why is there abnormal color of the stool in this condition? Which condition? What is the, I will say again, utilization of this chart or this card? How we use it?
For biliary atresia, EHBA, neonatal cholestasis, to identify early cholestasis.
Very good.
Biliary atresia, again, cholestasis, pale colored stool.
Right. Very good answer.
Cholestasis.
Let me answer. You
Yes.
know, if you're seeing this card, the first three colors, the top three, they are abnormal because they are clay color, then partially yellow, and light yellow. So we should be able to understand and make the parents to understand that if these type of the colors are there, they are abnormal. And lower down, 4 to 6 are labeled as normal. So that they can compare even what is normal and abnormal. Normal stool will be yellowish, brown, or greenish in the infants, particularly the newborns. And this abnormal color, if the parents decide, anybody is knowing the history of this card? Let me go in this way. Then I'm sure that you'll be able to remember. Anybody, what is the history or which country devised this card? And then what they got the benefits? Anybody? Let me wait for few minutes. If anybody is able to think, and I'm sure that it is a good way to remember. Lata, any response?
No, sir. I'm waiting for that only.
Yeah. Basically this card was initially prepared in some countries where biliary atresia is quite high, incidence is quite high. And what is the idea of this card? Even here in our country, what is the complaint of the pediatric surgeons for pediatricians for biliary atresia? That we diagnose late, we submit for the surgery or interventions late, and then outcome survival is not favoring. So here the point is early diagnosis, early referring the patient for the possible whatever the intervention is required, Kasai or some others now, that should be the early. And therefore, early identification, very simple, from the stool parents can decide. If the parents come back early, if the pediatrician is aware regarding this, we will submit the patient in time for the surgical intervention, and then outcome is favorable. That's the basic situation. And the countries like, probably if I'm not doing the mistake, I'm not sure, but probably Turkey was the country where this biliary atresia was quite high. They adopted this interpretation, made this start popular among the mothers, public. Patients started to come early to them, and they studied that, yes, it makes a difference in the outcome if the early treatment is done.
Sir, two persons have answered Japan, and Kalpana ma'am is requesting to show the card once again.
Yeah. Japan and I think Turkey. Japan was also there.
Mm-hmm.
Yes, I think this chart, again, I have used even my book, even both the books, Signs and Symptoms, and next this PG exam also. And that, again, the reason that if you are aware, if you just draw the attention of the parents, I think now gradually even the neonatologists, that every mother, you can just draw the attention that look at the stool of your child, and suppose the lower down, it's normal, but by chance your observation, that stool pattern is from the above 3, then come back to me. Just, I will say, explain the mother, it will make the difference. And I think yes, Japan, because Kasai surgery was devised in Japan.
Japan.
And that Japan and I think some other nearby country, sorry, I forgot it, but they are having the highest incidence. And after this simple, I will say, intervention of making this chart, that was the study that yes, it makes a difference. And therefore, my idea of asking this question, and I'm sure in the OSCE also people are going to keep it. I've seen in the OSCE once or twice that this card was there. And which condition already we have discussed. There is biliary atresia. The normal stool has a brownish color due to the presence of stercobilin, all of us know. In biliary atresia, stercobilin synthesis is markedly decreased because bilirubin cannot reach the intestine. And therefore, clay colored or the stool. I think here somebody may ask the question, every child may not be having the clay colored stool. Ideally, to confirm the clay colored stool, if the stool is firm or hard in consistency, cut it, and if you see the core of the stool, it may be pale. Because there is the shading of the mucosa. In the intestine, there is the shading of the mucosa. It will be yellowish. Therefore, it may give you the false impression of normal color the stool. But as a pediatrician, if you are the clinical doubt or possibility of biliary atresia, always check the stool appropriately and cut the stool and look at the core. That may be the pain. I think that is another thing which somebody may ask if the student is having a good scoring. And what is the reliability of this test? Scientifically, they have studied even that what is the reliability if you go for the interpretation from this test. And they said 90%. Look at the sensitivity, 90%, and specific 99. That means if you just see the simple clinical, I will say, manual, that gives a very good clear-cut answer for the diagnosis. Of course, then later on you can go for confirmation by the different tests and everything. But the point is, here as a clinician, what I want to convey that simple measures can provide you a lot many information, which sometimes your investigations may not be able to do it. Anyway, let us go further. A newborn was born with the following abdominal wall defect. This is the picture of the patient, which already long back I came across. And then my question is, just look at the picture so that you can remember what is the probable diagnosis.
So 4 persons have answered gastroschisis, 5 now.
Okay.
6, 7, 8.
Very good. Any other response?
No, sir, only gastroschisis.
Very good. But the examiner will not be so simple. You will have to explain that why it is the gastroschisis. Answer is right. What are the clues of the condition? From what clues you say that this is my diagnosis of gastroschisis? Anybody is having idea what are the clues? Or in other way, I will say, I'm sure the next question I have put in to differentiate from next condition.
So 2 persons answered not in a cavity like omentocele, no covering, not lined by membrane, there is no sac covering.
Very good. And a few points are there, but very important clue is not there. One more is very important clue. One very important clue mentioned that is not covering, but the very important clue is
not in midline. 1 person has answered.
Yeah, absolutely good. Abdominal wall defect is not at the umbilical. It is outside the umbilical ring. That is a very characteristic of this gastroschisis. If it is the umbilical ring, condition is different. So and second thing, very right, that not covered by the peritoneum. These are the very important 2 points to differentiate from other condition defects, that is the gastroschisis. And defect lies right to the umbilicus in this patient. But in short, it is not in the umbilicus, outside the umbilical ring, not covered by the peritoneum. And then what are the contents of this swelling? I think yes, contents can be anything. Please remember, it can be intestine, stomach, bladder, or even the uterus in a female child. So gastroschisis, all these contents are possible. Anyway, that's why I said I am going to put the next question. Similar. This child was also delivered with the below given congenital defect in the abdomen. Then what is this condition and how we can differentiate from the gastroschisis?
6 responses omphalocele.
Okay, very good. But the point is, how will you differentiate?
Midline, somebody has written.
Okay, we have
covered by peritoneum.
Right, good. Anyway, already diagnosis is given, that is omphalocele or exomphalus. Please remember, rather than telling it midline, better to call it not in the umbilical ring. That's a very important point. And differential diagnosis are already an example as hernia of the umbilical cord, even gastroschisis. This will be the differential diagnosis. How will you differentiate from other conditions? Again, please remember, already we have discussed. Omphalocele is the herniation of the intestine from the base of the umbilicus. Yes, and it is covered with the intact skin, which is not there in the gastroschisis. Another thing, how to differentiate from umbilical hernia. Umbilical hernia and omphalocele, what is the difference? That difference is between the width of the umbilical ring. If that gap is more than 4 centimeter, that is omphalocele. Gap is less than 4 centimeter, that is umbilical hernia. You know why we are discussing so much? If it is umbilical hernia, I can wait. It will disappear. Most of the children, unless go for the complication. But if I say it is the omphalocele, it requires surgery. It is not going to disappear. So this is very important point, omphalocele and umbilical hernia. Very small point for the differentiate, that is depending upon the size of the gap, or that is the umbilical ring width. And then, but it makes difference in the management of the patient. What test should be performed? Suppose if you have got the antenatal diagnosis, because this condition associated with some other problems also. Therefore, anybody, what test should be performed for antenatal diagnosis?
No answers till now, sir.
Anyway, one is ultrasound. But you know, ultrasound, if you detect, you know, this omphalocele, gastroschisis, nowadays, antenatal sonography, you are getting the answer. Problem is there. But here with this omphalocele, better to go for the karyotyping of amniocentesis or choriovenous sampling for chromosomal study, because they say that chromosomal abnormality may be in 40% cases of omphalocele. Therefore, it is very important to go for the karyotyping, because it is not simple omphalocele, but suppose some chromosomal abnormality, which involves even the other system, particularly the CNS. It requires a proper genetic counseling to the parents, whether she can continue the pregnancy or not. So I think this is not just for identification of the condition, but having all the understanding of his interpretation and diagnosis. Let us go to the next. Yes, even what is the immediate management? That is also very important. Before you go for the surgery or anything, what is immediate management? Please remember, it should be nursed in the supine position. The sac should be supported both sides. And even the diluted povidone, iodine or mercurochrome should be applied on the surface to facilitate the epithelialization before the surgery. So I think this point of management comes on the pediatrician side before sending to pediatric surgeon. So that's a point which you can remember. Final management, of course, all of us know, surgical repair. Associated anomalies, syndromes. So this is very important for us to know. That associated may be the congenital heart disease. So check for any murmur, cyanosis. Genitourinary defect can be there. Some craniofacial, musculoskeletal, vertebral or limb skeletal anomalies. Even maybe with the Beckwith-Wiedemann syndrome. Maybe even this trisomy 13 and 18. Not Down-May, but these are the adverse syndrome, Patau syndrome. I'm sure that all of you remember. So these are the points which we can remember. Very simple. This can be the spot diagnosis in MD examination. And then Viva will be there.
Cleft lip. Somebody's answered. Cleft lip.
But you know, for MBBS student, okay, that's right answer. For PG, no.
Yes.
PG, you know, to mention so many things. Unilateral, bilateral. It is incomplete, complete. Right? It is isolated, cleft lip, cleft palate, or really complex. So therefore, to get the marks, I will say appropriately for the good scoring, in the exam you go with the preparation, okay, how I will answer. Your answer should be very right, appropriate. And therefore, it's a cleft lip and cleft palate. Both are seen, obviously. Classification, as I said, is very important. Isolated cleft lip and cleft palate. Then unilateral or bilateral. It is complete or incomplete. So try to answer in this way. And now I think if we come back to our picture, is it cleft lip and cleft palate? Both are there, right? It is unilateral or bilateral.
So somebody has answered unilateral incomplete.
Yes, it is unilateral and incomplete. Perfect answer. So I think now I'm getting the answer. So this is the work of, I will say, teacher, that sensitize them. And I'm sure that those who are listening, by chance, if they get similar case in the exam, the response will be different because they know. So that's the thing. Combined, even the cleft lip or combined cleft palate, unilateral, bilateral, complete or incomplete, syndrome even sometimes. What are the clinical problems with this disorder? What other problems or in the management or the parents may come to you?
Aspiration.
Very good.
Feeding issues.
Right.
Aspiration again.
Yes.
Feeding difficulty, aspirations.
Yeah. So please remember these problems for the good against scoring. Feeding aspiration, everybody will say. But if I want the good scoring, I should remember other things. Feeding problems, nasal deglutition, aspiration, yes, but with that, middle ear infection is also common. With that, speech problems also, even after repairing also. Due to that, even the psychosocial problems to the child, even the dental problems. So I think these are the things which we can remember. These are the clinical problems. And therefore, it requires even the teamwork, not just repairing. What is the current recommendation treatment schedule? At what age that means you should go for the correction? Anybody?
Lip 3 months, cleft lip at 3 months. Two
Okay.
responses.
You can see now what is the long list.
3 to 6 months.
For MBBS student, okay. Lip 3 to 6 months, usually I will say 3 months is right. Palate 9 months, at least before the child starts to speak. But 2 years, even after that, you have to go for speech assessment, may require the speech therapy. So just surgery is not only sufficient. Sometimes it may require even the lip revisions for the scar and other things. 8 to 9 years even, there may be some orthodontic interventions. Even in the extensive bilateral cleft lip and cleft palate, it may require alveolar bone grafting, nasal revision, and even orthodontic surgery in adolescents. So I think as a pediatrician, in the practice also, nowadays, the time has come that only just repairing is not sufficient. So we'll have to remember all the things. I think Lata, once the time is over, you can just inform me.
Yes, sir. 6 minutes still left, sir.
Okay, so
You
I
can
think
carry on.
one or two we'll do.
Yes,
and then
sir.
we can end over that point. This was a 2-year-old child presented with constipation since almost birth. There was history of delayed passage of meconium, more than 72 hours. I have answered, but somebody will ask the question, what is delayed passage of meconium? And the radio imaging study was performed, and the picture is given over here. I think so obvious answer.
Yes, sir. Congenital megacolon has answered Harsh from before asking your question, they have started writing diagnosis.
But my question is different.
Yes, sir.
Therefore, the people are going to ask you the different question they are asking. What the radio imaging study is it? What type of the study is done? What is the response?
Contrast enema, barium enema, ultrasound, lower GI contrast. Barium. Barium contrast enema. So barium enema and USG.
Good. So that is the barium enema study. Now the diagnosis. What is the diagnosis?
Hirschsprung's mostly have answered.
Yes, it is the Hirschsprung disease. What clinical examination suggests the high probability of the condition? That means that clinical examination is very important for the pediatrician. Most of the times it is missed. Therefore, I kept it here as a question.
Olive-shaped mass, empty rectum,
Very good.
passage of fecal gush.
Right. Very good. I will appreciate that they are aware of it.
Yeah.
That's good. Rectal examination in short. I remember Dr. Anjana Ben, very senior pediatrician. She used to say any patient or constipation, if you don't do the rectal examination, not pardonable. In the MD examination, some examiners were not ready to consider you. So the point is, rectal examination is very important. And I am talking that when the investigation facility was limited available to us. And what you will get on rectal examination, that rectum is felt to be empty. In a functional constipation, rectum is loaded with the fecal matter. Here, Hirschsprung disease, rectum is empty. And once you remove your finger, examination finger, you will get the gush of explosive passage of flatus and feces. Very classically remembers these senior people, they will say it is Hirschsprung. No need to go for confirmation. Nowadays, it's not so. And therefore, the next question is going to be there. What investigations? And what is the confirmatory investigations? Other investigations will be suggesting. So what investigations we can perform in such patients? And which investigations will be confirmatory?
Rectal biopsy, ACHE, rectal suction biopsy,
Very good.
rectal biopsy.
Good. You can do the barium enema, which already we have done in our patient, and that it will show the aganglionic narrow segment and a cone-shaped column at the junction of the ganglionic and aganglionic segment, endorectal manometry, and of course, please remember in the rectal biopsy, it should be full thickness. Just if we take the superficial, may not give the diagnosis. So go for the full thickness. I think this is the job of the pediatric surgeons, but I know that they are doing the good job, and that will show the lack of this or absence of the ganglionic cells. And that becomes the diagnosis, and you can submit the patient for further surgical interventions. Line of treatment, removal of the aganglionic segment of the colon by surgery is a line of treatment. But suppose sometimes very long, sometimes they may have to go for the colostomy. And then they can go for this total dissection. And it may require even extensive, the whole colon, sometimes beyond that also it is possible. And then the short bowel syndrome will develop later on to the child. That pediatrician has to manage later on. Anyway, let us come to the, I will say, gradually end for the today's session. A 3-year-old boy from Rajasthan was referred for chronic diarrhea, failure to thrive, and bilateral pedal edema. The diarrhea started at the age of 1 year, and on examination he had severe anemia, bilateral pedal edema, and multiple vitamin deficiencies, despite good appetite and dietary intake. Mother will say, takes good food, good diet. It's not decreased appetite, but still the problem is there. I will say each word is important if you are following it. And then my question is, what is the probable diagnosis? I'm sure a lot of responses will be there.
Yes, already. 4, celiac disease.
Celiac disease. I want to convey to the friends to understand why. 3 years, that means after the infancy, problem started after 1 year. Why? Because, that's the time for the complementary feeds. That means wheat containing complementary feed started. And then the story starts. So that's a very important onset of disease, where it started, at what age. Second, it's a chronic diarrhea, it's a presentation, but malabsorption syndrome. But please remember, every patient of celiac may not have even the chronic diarrhea. Absence of diarrhea does not exclude it. Some children may present with even the constipation. It is also possible. Failure to thrive, yes. And anemia, what type of anemia? Iron deficiency, but that is a refractory iron deficiency. Does not respond to the iron therapy. Pedal edema, again, is due to the hypoproteinemia, because there is a malabsorption. And malabsorption leads to the multiple vitamin deficiencies also. So simple to understand. If you just listen to the story, that yes, this and diet is normal, because it is not any inflammatory or infective condition. It's an autoimmune disorder. And therefore, probably diet may not be the issue. Decreased appetite, on the contrary, with the loss, the voracious appetite may be the story. But my question is next. What are the differential diagnoses with this type of observation? I put the Rajasthan, because in the North Belt, celiac disease is common. Again, the reason is people are telling that there is some genetical tendency over this population. That is the basic problem what they have located. But then, what are the other differential diagnoses, suppose? One of the patients I remember, let me admit over here, I diagnosed celiac disease from the clinical presentation and from tissue transglutaminase. Parents refused for the biopsy. So I could not do, and therefore I explained long back, probably celiac disease. After 6 months or 1 year, I remember I got the response from one of the pediatric gastroenterologists that, sir, your patient has come. It is not the celiac. It is some other. And therefore, here I have put the question, what are the differential diagnoses?
The protein losing enteropathy.
Right.
2-3%.
Protein losing enteropathy is the syndrome. Anything can be there. Which conditions will present with the protein losing enteropathy or malabsorption? Which conditions? One is the celiac. What are others? Conditions.
Tropical sprue, one has answered.
Okay, tropical sprue will have the different presentation.
It will
May not be so classical.
HIV.
Yes, good.
Good diagnosis.
HIV.
Pancreatic disorder, cystic fibrosis, Whipple.
Very good. Anyway, giardiasis, don't forget, in our country. I've seen even with some patients that exact similar presentation. Cystic fibrosis, yes, very good. HIV, yes, even tuberculosis. Not so common presentation, but malabsorption syndrome is known in tuberculosis. And lymphangiectasis, in my patient later on, they went for the biopsy, turned out to be the lymphangiectasis. Child was operated, recovered very nicely. So these are the differential diagnoses which we should keep in mind. What test should be performed for confirmation of diagnosis? I'm sure that you will mention the serology, CBC and everything okay for refractory iron deficiency. Serological test more reliable, anti-gliadin IgG and IgM not much reliable, so better not to do. Tissue transglutaminase, yes, more reliable, but highly suggesting, you can say, not the diagnosis. Even endomysial antibodies, still better than tissue transglutaminase. But the confirmation is the biopsy. And even all our gastroenterology associations, their guidelines, European Society, Indian Society, that biopsy is must for confirmation of the diagnosis, because we are going to put the child on the gluten-free diet for the lifetime. So should we end over here, Dr. Lata?
Yes, I think it's already 10:35.
Yeah, that's why.
We are enjoying session a lot, but sorry to say, I have to end here.
Yeah, but I'm sure that from where we stop, we will start from, I will say, further next time, and many sessions will be there. It's not, I will say, ending the story. So we'll continue. and I'm sure that every time we learn a lot. So thank you very much again to even I will say organizers and I will say people behind this whole show, Dr. Yogesh Bhai, Dr. Nehal, Dr. Lata, and the whole team, even our office bearers, Dr. Jhankhana Ben. Again, I think Dr. Nehal is the office bearer. I will say every place she is there, whatever the position we say. So, but again, I will say to be very frank, I'm not sure how much the students are getting benefited or practitioners. I am getting maximum benefits. And I really love to interact with you all the friends. I will say so fantastic responses were there. And I'm sure that in the coming days, more students, more people will be involved and will enjoy the whole journey. Thank you very much, all of you, for giving this opportunity. And thanks a lot. Before we end, at least let me hand over to Dr. Lata or Dr. Nehal and others.
Thank you.
Thank
Thank
you.
you so much, sir. As always, it was a wonderful journey through the learning. And we all admire you like anything for this. You are teacher. For me, you are teacher, my examiner, my external examiner who passed me out for the pediatrics, and I always remember it. So, thank you once again, sir. Students are asking for the next session. When is the next session? So,
I think Nehal Ben can answer that question. I don't have the answer.
So, students, this session is going to be there every week on Thursday from 9 to 10:30. But we have the different formats, and the magic of this format is like today we had the OSCE by Sir on the gastroenterology. Now, next is case presentation by one of you on the gastroenterology only. Then on the third session, you will be having the expert talk and the panel discussion on most of the gastroenterology topics. And then on the fourth Thursday, from whatever you have gained knowledge from all these three Thursdays, you will be getting a quiz. So that will be a refreshing knowledge and the knowledge test for also you by yourself. So please be engaged with all the sessions and so you will enjoy the quiz also. So my best wishes for every Thursday and please be there. But yes, please interact. This time you have wonderfully interacted with the chat. But for case presentation and a question answers, I think sir will enjoy more if you answer his question in the case presentation. So please join the case presentation next Thursday from 9 to 10:30.
At least let me inform Nelvin that I have the more than 700 OSCE prepared in my pen drive. So at any time, whenever you suggest, I'll be able to do. Let me take the liberty to show this my book. That this is on the absolutely for. I am not sure whether this will be able to read or
this
will be
is
different
Yes,
way.
it's okay. Now it's okay.
But at least to convey that this is sure, even I will say all the different manners, methods of the PG exams are included and it is going to be beneficial. Thank you very much again and good night.
No, somebody is asking for the
comment.
iPhone and the Samsung. Who wants to comment?
Yeah, please
Please,
come.
Yes, yes, please.
First, please rename yourself so we can ask or we can call you by your name. So it is better to understand other people also.
Yes, yes.
So iPhone and the Samsung.
And please, even these comments or some suggestions definitely will be useful to all of us. So please come on.
Sir, I think Samsung to મારો ફોન છે ડોક્ટર
તો મેડમ
કૃતિકા.
બદલો ને પ્લીઝ.
અરે મને શું કહેવાય કે આજે પહેલી વાર કંઈક મારે એ કરવું પડ્યું. હું કરી
તમારો
દઈશ
ફેસ દેખાડો તો
નેક્સ્ટ
પછી
ટાઈમ કરી દઈશ હું.
નહીં વિડિયો ચાલુ કરો તો we can recognize you by name.
અરે કૃતિકા ને હા ચાલો કરું.
Yeah, it is better ને we can. Yeah.
Actually sir your journey અને જે બધું તમે કર્યું મતલબ બલદેવ સર ને sir really it is fantastic. ખાલી મેં કમેન્ટનું એટલા માટે કીધું કે the things OSCE when I heard or the title then I thought that it is usually in medical education we say that it is observed structured clinical examination. So it is more for a psychomotor skills. So whatever sir has taken us, it is some case-based learning, and then I think in DNB, OSCE, maybe using that word, but in correct sense, it is more for a psychomotor skill,
Yeah.
what I feel. And this is like case-based learning. So it is know how till that it matlab, assessing the student.
Yes,
So
I mean,
OSCE word OSPE and OSCE. So for preclinical, paraclinical, OSPE, and for clinical side it is OSCE.
yes.
So just I thought that how in online OSCE. Maybe
Yeah,
I'm
yeah.
I'll.
Now for your information, that it has been changed as the objective structural clinical examination. And DNB has now changed the format. Since last year, even I am in the central DNB office also for giving the questions and forming and training even the faculties for framing the questions. And for that, now you know that initially when the DNB exam started, it was physically the student will be there and even the stations will be there. That was the format.
So,
That
sir,
was the format.
yeah.
But
So actually,
later on with the more numbers of the students, and even the every time it was not possible that
yes, sir. That
physically, and therefore now online exam also, you know, it is online. So
yes.
in online it has been broader, that rather than only the specific instruments or asking or something, we can go for this even the case scenario, instruments, or even
Yes, sir. Yes, sir.
something.
So
So
for undergraduate, what suppose this time practical prelims we have to
yeah,
take. So in that seven मतलब unmanned जो अभी आपने मतलब what you have taken photographs and case base and instrument everything. So 70% that, and then three stations will be of that main station. So on the patient, so head circumference लेवानु मतलब
right.
that sort of thing. So mixture of both. So OSCE, I thought that only for those main
No.
stations.
Now,
Uh,
now that concept they have broadened for
yeah.
this conducting in this way, the online also, and therefore I will say format have been broadened in this way. Even in the DNB, and I think being all of your teachers, you must be knowing that even many universities in the MD examination also, NMC has suggested that, but that you should also go for asking the MD examination. Some
Sir,
universities have accepted, some universities, due
Time,
to
I think.
the
Sorry.
logistic problems of management, they are still reluctant. But I'm sure that in the near future, NMC will say that every university will do, then probably we'll follow it. And because I know even these NMC norms also that after some time, till they are given some option, afterward they will stop the option that now every university should do. So therefore ultimately this will be the, I will say, pattern. Almost 20 marks probably they have decided for the MD. Some people say even the 40 marks, but you know in the DNB there are 100 marks, that 20 OSCEs and each mark 5 marks. I think all of you, I know that you are in the DNB examiners, so you are aware of it. So I'm sure that's why probably students will be more interested and more beneficial.
Sir,
Thank you very much.
and myself is Kalpana, Dr. Kalpana. It's a wonderful session and very lucid way you have taken, and the very intelligently you started with the very common disease. So everyone will answer and they will feel
Yeah.
empowered and they will feel more excited. That's a very good thing. And second thing, from 2023, NMC said it's must. So the postgraduates who are going to appear in 2026 this year, and the OSCE is must, but we are doing for the last 2 to 3 years. And what we used to do, one is OSPE, as she said, the pre-clinical, but we
Yes.
do in a practical basis. So we keep four stations and one observer. Like we used to give one the counseling part, one is the breaking the bad news. Counseling means for the chronic disease like any leukemia patient and diabetes patient and all. One simulation for CPR and one
Yes.
any other disease. So we
Absolutely.
also we keep 20 marks for that, in each station. This we have started in our college for the last 3 years.
Yes, madam. Right. Absolutely right.
Thank you.
Thank you, sir. Thank you very much for
Thank
the
you,
excellent
all of
session.
you.
Thank you, sir.
And
I
the
think
most of
beginning is good, and then the whole show is going to be good.
yes,
yeah.
sir. Yes, sir.
Thank you.
Thank
Thank you
you
very
and
much.
good night. Thank you for
Yeah.
Thank
inviting
you.
giving me a chance to speak.
Good night.
I'm
Good night.
really honored to be here with you. Thank
Madam,
you.
I will
Good
I
night.
will post every time, every week.
Yes, sir. Yes, sir.
Yeah.
Thank
Thank you.
and good night.
Thank you,
Good
everyone.
night.
Thank
Good
you.
night, all.
Good night, everyone.
Thank
Good
you.
night.
I think Lata did the good job.
Thank you,
Thank you,
Dr.
sir.
Lata. Yeah.
Thank you, sir.
Nehal madam is already now, she's
Yes,
a
yes.
seasoned Kheladi. You are the newcomer, deputy, and you have made the century.
Thank you, sir. Thanks a lot.
Thank you.
Thank you. Good night.
Good night,
night.
everyone.
Good
Good night,
night.
sir. Good night, ma'am.